Okay, good morning, everyone. Welcome to this morning's Grand Rounds. I get the pleasure of introducing one of our fifth-year residents, who's one of our co-chief residents, Dr. Gutgsell. She came to us from Western University College of Osteopathic Medicine, and I've had the pleasure of working with her ever since she was a fourth-year medical student, and she's done a phenomenal job. Starting in November, she'll be joining us here as one of our faculty. And today we get to learn about prevalence of abnormal brain MRI findings in the pediatric migraine population.
Happy good morning, everyone. For those of you, obviously, that don't know me or probably know me, I'm Crystal. So today, I'm going over a research project that I actually happened to do with two other residents, as well as Dr. Bhatia and then Dr. Kuwabara as well. It is a retrospective study in the pediatric migraine population, and as the title says, basically looking at abnormal brain MRI findings. So to kind of begin, disclosures per usual as a resident, none. And then again, special shout out and thanks to everyone who helped out with this project, which was quite an undertaking. So the objectives today for my presentation will be number one, to explore prior retrospective studies done in children and adults on this topic, primarily children, of course. Briefly review diagnostic criteria for migraine and when we consider imaging. I think in general, everyone has their own little bit of criteria of ordering MRIs and things as well. Review the methods used to create the retrospective study we did here at PCH. Number four, analyze the findings that we did with this study and then further discuss the opportunities for research in this area. So just a little bit of background. Sorry, it was taking a second on my end. Migraine in general in the pediatric population of all the headache types is the second most common primary headache disorder. And one very, very large study looking at the general pediatric population and the prevalence of migraine in there found that about 11% or 1 in 10 patients suffer from migraine. So, I mean, and in our practice, I feel like as neurologists, probably at least a third to a half, unless, of course, you've subspecialized. The main concern for parents, especially in these migraine patients, are, sorry, just double checking something. So, is there like a mass or a tumor? That's always kind of the big kind of question or concern, or is there an aneurysm in their child? There was a meta-analysis also done in patients without any sort of neurological symptoms who were undergoing brain MRI to see how many of those actually had any sort of brain tumors, and only about 0.7% were found to have this. The study was a little bit interesting, the way that they did that. They looked at, when they accumulated some of these studies, they looked at basically controls of patients and only used those patients to see if they had any sort of incidental findings or neoplastic findings, and used those and kind of obviously conglomerated them all to get that number, but very large undertaking. Another sort of study done in Turkey, this one and the next one, both done in Turkey. They must really be passionate about MRI brains and the pediatric population and migraines. So with these children, with the Gurkha study, this one looked at a total of 478 patients, but really there was only 407 of the patients actually got MRIs performed. Of those patients, only 5 of them found some tumors, one of which had a frontally located low-grade glioma, or low-grade tumor, yeah. So the second patient had a primitive neuroectodermal tumor. The third had a neuroblastoma. The fourth had a craniopharyngioma, and then the fifth also had a low-grade glial tumor as well. For that study specifically, it found the kind of number one incidental finding that they found were white matter abnormalities in about 10% out of the total patients tested, with perivascular spaces being the next. For the Yilmaz study, also done in Turkey, this one found that 2.9% of primary headache patients, this includes, tension headache, migraine, things like that, found that those patients had about 2.9% of those patients had any sort of significant finding, and really there was only one case of a malignant tumor in the 324 patients. So they, sorry, I didn't mean to go back. There we go. Of those patients, they did a total of 449, so another large study with 324 of them actually getting MRIs. Most of them had migraine. Secondary was tension. Then they also did secondary migraine and then quote unquote unspecified. In those ones, two of those patients were found to have the relevant findings, one of which was, again, as you saw, the malignant tumor. The second one was ventriculomegaly that required a shunt. In this study specifically, compared to the other one and maybe compared to our findings, the incidental findings, the number one finding did seem to be, again, white matter hyperintensities. 2 was old infarcts, 3 was Chiari malformations, and kind of so on and so forth from that perspective. The interesting about this one, rather than the other one, and also from ours, was primarily looking at intracerebral findings compared to, or looking at intracerebral and extracerebral findings, which they also looked at. Okay, is there sinus disease? Is there adenoid vegetations? That sort of thing. So overall, looking at quite a few different studies and a lot of references in the end, about 1 to 3% of patients, both kind of in the pediatric migraine population as well as the general population, in the general population, even less than that, had significant findings on MRI. Of those, 1% had potentially, 0 to 1% had potentially intervenable findings, including the brain tumors and hydrocephalus. So just briefly, as many of us know, the ICHD-3 migraine criteria, just to review for those who haven't maybe thought of it in a while. So there's migraine with and without aura. So without aura, and basically we would look at how many attacks did they have, hopefully at least 5 attacks. Headaches lasting between 4 and 72 hours. However, in the pediatric population, we usually think greater than 1 to 2 hours. A headache that has at least 2 of the 4 following criteria: unilateral location, the pulsating quality, moderate to severe in pain intensity, aggravation or causing avoidance of routine physical activity, walking, climbing stairs, that sort of thing. During the headache, it must have at least 1 of the 2, nausea and or vomiting, and then photophobia and phonophobia. And of course, not better counted for any other ICHD diagnosis. And then, of course, similar thing with migraine with aura. This time, of course, with aura, you will have some sort of, whether it's visual, sensory, speech, some sort of thing that happens either before or during the migraine itself. And then at least 3 of the following 6 characteristics. Basically, at least 1 aura spread gradually over 5 minutes, 2 or more symptoms occur in succession, each individual aura lasting 5 to 60 minutes. At least 1 aura symptom is unilateral, at least 1 aura symptom is positive, and then the aura is accompanied or followed within 60 minutes of that or prior. All right. So, let's see here. Oh yeah, so our kind of rationales and objectives for doing this study was, when we were initially doing the lit search, it was like, okay, how many across the entire world even have any sort of specific pediatric migraine study that looks at any sort of brain abnormalities? There were a lot, like discussed previously, in Turkey, where they're looking at the multiple different primary headache disorders, or even some of those that included secondary disorders as well. There was one pediatric study done in Italy that did look at just pediatric migraine. However, with this one, compared to ours, I mean, this one was very extensive and quite well done. It really looked at the amount of gray matter atrophy in pediatric migraine patients versus controls, because they actually compared that to an adult study where they did see that there was atrophy in the gray matter in specific regions in migraine patients, so they decided to do that in the pediatric populations as well. And they did find that there was statistical significance of atrophy in the frontal and temporal lobes as part of kind of the pain processing network. So that was just interesting and very, very interesting. As far as other rationale, I think from our standpoint, it was really to give kind of parents and providers, whether that's neurology or general pediatrics or whoever orders brain MRIs in this patient population, give them some sort of reassurance in the end, and then kind of provide some updated data as well. So the objectives that were specifically written within our IRB were, number one, to identify the MRI orders or the reasons for MRI ordering the MRIs in migraine patients, and number two is estimate the prevalence of abnormal findings in this population, investigate the prevalence of the relevant / intervenable findings versus the incidental findings, and finally determine whether imaging really changed management in the end for those patients. Alrighty, so going into kind of the methods that we did, this was a fun learning thing for me because I did not know that a retrospective study need IRB approval, and that was a fun process, as it is for anyone who does any sort of research, but this was extra fun trying to figure that out. So we took data collection through kind of SCM with the help of some of our IT team, and I looked at data basically from August of 2021 over through August of 2023. And the way that we kind of extracted that data from SCM was really taking the ICD-10 code G43.001.011, that sort of thing. And then finding those patients who actually had migraines, MRIs. So as far as collecting and reviewing that, whenever the collection part, now reviewing, we reviewed 320 charts. Could we have done more? Yes, we could always do more. But that was the amount that we got out of the 2-year span. And we really kind of looked at a lot of different things. We really had to kind of verify the diagnosis. Number one, that it was like not just I'm just going to click this ICD-10 code because we think it kind of meets the criteria for migraine. We had to double check that. We had to double check the physical exam findings, as I'll get into it in yet a moment, with the inclusion and exclusion criteria. We wanted patients who had a normal physical exam because obviously if you have a focal deficit, it's probably not migraine and not something that you want to miss. 3 was the reasoning, looking at exactly why was it even documented why the physician or APP ordered the MRI. 4 was kind of double checking who had ordered the MRI, because primarily for us, we used the patient charts who had MRIs ordered for pediatric migraine patients from the neurologist or the neurology APP. There were a lot of kind of neurosurgery patients that kind of sprinkled through. So those ones were sort of excluded. And then also ones that came from the emergency room, they had ordered an MRI, but we did not include those. I'll go into that a little bit more in a second. And then we reviewed all the abnormal MRIs as well. So each chart was checked at least twice by one child neurology resident. And then on top of that, actually, we would even have sometimes a third child neurology resident look over it. And then also Dr. Bhatia for these ones where it's like, okay, when we're getting, things can be a little bit difficult with inclusion versus exclusion criteria, because no patient, is really easy. I would have to say that with the study. There's about 5 to 10 at least, plus a lot more that were very difficult to kind of really decide whether or not to include or exclude them. So the data points that we looked at, but the ones that I will primarily be going over would be the MRI findings today. we looked at age, gender, ICD code, family history of migraine, the treatment used in their migraine, and then the types of MRI ordered, which I'll go over briefly as well. But we really separated into normal versus abnormal. Those abnormal MRIs were re-reviewed with a neuroradiologist, Dr. Kulbara, to see if he agreed with the study findings and or did he find anything else on top of those studies. We really looked at kind of the relevant or intervenable / further workup or referral patients, put those into one category, and then incidental, into another category. And then again, reasoning for MRI was another one. So the inclusion criteria that we used in our study was basically the ages, excuse my typo, ages between 5 and 18 years of age. The diagnosis of these patients obviously were based on the ICHD-10 criteria that we discussed previously, and had to double check that those were kind of within those criteria. They had to have underwent a brain MRI, otherwise what are we doing this for? And then number 4 is the kind of the availability of the data with complete information. So the kind of thing that we were running into sometimes with these patients, which it'll go into the exclusion criteria in a second as well, but sometimes there was, whether it was like done by an ED provider, or we didn't have a whole section missing, or they forgot their physical exam, something like that. And then we go from there. So exclusion criteria, of course, patients outside of our age range, because it would be a little bit unusual to have anyone with migraine less than 5, and probably should get an MRI in those patients. Incomplete records, basically a little bit what I was alluding to before. One of the things that we kind of put into this category was also patients who had braces, and it was really obstructing the view, because in that way you don't really have a complete picture of the MRI and really of the full hemispheres to really double check that there's nothing there. Non-migraine headache diagnoses, again, this was primarily done for migraine pediatric patients, not tension type, not cluster, just migraines. Non-headache workups, so a lot of those that we found were a lot of patients who had epilepsy also had migraines, and a lot of them were doing kind of further surgical workup or pre-surgical workup with MRI and things like that, so we did not include those. And then previous neurological conditions, having other comorbidities such as having MS or something like that would kind of take away from or we would take them out of the study. And then abnormal physical exam findings that I kind of discussed previously. And then another one we excluded, which was kind of tough because we're a little bit back and forth between us all, is really doing repeat imaging for the sake of repeating imaging to see what the prior incidental findings and seeing if they changed at all, not necessarily in the context of headache, and that was given as reason a couple of times, so we excluded those as well. The transient physical exam findings that we can see in aura patients, we didn't use as an exclusion criteria because in that moment when they were being, I don't think any of the ones that were actually in our study had any actual aura symptoms during their actual examination with the neurologist. So if there was any sort of like true physical exam findings that were, more than what you would either expect or, normal kind of variants of the neurological exam, we kind of excluded the ones with an abnormal neurological exam. So, yes, looks a little funky, but that is A-okay. So some thing that you're probably thinking, you're like, okay, well, what about the Snoop kind of mnemonic that we use in general for red flags in patients with migraine, which I think in general we all very much agree when we have patients with any sort of Snoop symptoms, we do get concerned. And the ones that we kind of looked at, we didn't basically use it as a main criteria for excluding or including certain patients. The ones that we did include were the ones that were more like subjective findings. So the ones that we definitely didn't use, and we would double check as far as the vital signs, was if the patient is having fever in the setting of headache. I wouldn't want to miss meningitis. If they had a history of brain tumor, they were excluded. And that was also seen in the exclusion criteria. A neurologic deficit, again, in our exclusion criteria. Onset of headache is sudden and abrupt. Again, we're not thinking migraine in that patient. Older than 50, well, we definitely didn't have that. Pattern change or recent onset of headache. Now, none of these had new daily persistent headache. They all, again, met criteria for chronic migraine. So we wouldn't have used those, but ones with a pattern change we did use, more of kind of a subjective finding. And yes, can it be a potential neoplasm? Yes, but not always. And the differential is quite broad for that. Positional headache was used, and then precipitated by sneezing or coughing, we also used that as well. Papilledema, we did not include if that was found because you need more urgent imaging in that instance. But however, not all neurologists or APPs in these studies did do a fundoscopic exam. They may have done it previously, but we only looked at those patients in the certain time period we were given. Progressive headache or atypical presentations. We did use that one in our study. And then finally, pregnancy, painful eyes, post-traumatic, HIV. I can't even read this last one. Medication sort of overuse with opioids. Again, these ones we didn't necessarily include because you're thinking of other things in that situation. So kind of going into the abnormal MRIs, basically we kind of looked at, of those who required further workup or referral, basically who got further workup or referrals, who did not. Were there any significant interventions such as disease modifying therapy, etc.? And then the abnormalities we had found were white matter hyperintensities, pituitary abnormalities, cysts, anatomic variants / other, which I'll go into in a moment. And then actually, of the abnormalities found, we did not find any tumors or large vessel abnormalities in our study. And then we looked at also the reason for MRI, which I'll go over in a second as well. So the results of our study, I realize I didn't really go over that bullet point up a couple slides ago. So we did actually end up excluding quite a few patients. We were very strict in our criteria because, again, we wanted purely pediatric migraine patients without any focal deficits or anything of that nature. So total, it were the 320, which we looked over multiple times, and then 165 were the ones that we actually included in the study. So a little bit more than half of them, basically 76% were found to be normal. Of the abnormal MRIs, about 23.6% were abnormal. Of the abnormal MRIs, incidental was 21.2%. And then finally, relevant referral or further workup patients, 2.4. There was about 4 of those patients, and about 2.4%. Of those relevant patients, were there any clinically significant that change management? Surprisingly, no, but I'm going to go into kind of like each of those 4 patients as well, just because you're probably curious about that as well. I know in general, what do we, obviously, as you can see, primarily use as our basic screening MRI was the MRI brain without contrast. There were only about 12 that were with and without contrast. And then as far as doing like a little bit more studies on top of it, about 17 did it with vessels. MRIs without and vessels, there were about 13 of them. And then MRI with and without the added vessels was about 4. There was one MR1 bang fast / stroke, whatever we want to call it now. But that's a very quick one, primarily as the neuroradiologists love to say, it's primarily for looking for any sort of ventriculomegaly or hydrocephalus in that instance. All right. So kind of delving into the abnormalities found on MRI. So number 1, similar to the ones that we saw in the other Turkish studies, was the white matter hyperintensities found at 10 out of the total, about 10%. The second most common was anatomic variant / other, which again I'll go over in a moment. Third most common were cysts, and then 4 was pituitary abnormalities, and then about 8% had like a combination of these ones. So you kind of put them in a separate category. They're not in this little pie chart. The pie chart with those percentages obviously do not reflect the table's percentages, just because we're looking at it as a pie. Basically, 32% of that those abnormalities found were white matter hyperintensity. So just kind of giving a better like depiction of what that looks like. But I had a lot of fun making pie charts on this. Kind of going a little bit into each category that we looked at. We were very meticulous, I'll tell you that, with some of these patients. The cyst abnormalities that we found: arachnoid cyst, choroidal, pineal, pituitary, cavum, septum pellucidum, and nasopharyngeal. Again, that's more of an extracranial finding. Could we have used it or not? We were still kind of back and forth. We did use some extracranial ones, but that was the one that was mainly a cyst, so we used that one. As far as the anatomic variant categories within these, so sorry, let me just scroll down ever so slightly. I just want to give you kind of exactly what we were looking at. So within those cerebellar ectopia, none of these patients actually met criteria for Chiari-1. And then the next one was kind of vessel abnormalities. Within that, found that there was one with an atretic P1 of the right PCA. 3 of those vessel abnormalities were developmental venous abnormalities. One of them was a tortuous ICA, and another one was a very, very small 3 millimeter. I mean, maybe that's relative. Maybe it's large to a neurosurgeon. But one very small CPA aneurysm as well. As far as the cerebral variants, you're like, okay, what ones were those? So one of the patients showed mildly prominent ventricles and a thin corpus callosum. One of them had a rotated hippocampus, and then 2 of them had subependydymal gray matter heterotopias. And the anatomic variant that was other was rectus muscle hypertrophy, which curious for any sort of Graves' ophthalmopathy. Let me see. As far as the patients with cerebellar sort of ectopia, something that I kind of looked into a little bit further, I wanted to see if any of these patients had any sort of findings of or signs or symptoms of kind of cerebellar signs. And not all of them did. One of them had worsening photophobia and headaches, like that was their thing. There really wasn't much else, like that was the reasoning for getting the MRI in that patient. So this was more of an incidental finding. And one of them had dizziness and trouble focusing. The other one had vertigo. Another one had family history of brain aneurysms, and then another one had worsening headaches. So not a lot of basically none of them had very specific, and of course they didn't have any physical exam findings kind of consistent with any sort of large cerebellar worrisome lesion, which obviously was not very worrisome. The pituitary abnormalities, just going into those super quickly, normal, well, not normal, but slight hyperplasia of the pituitaries, pars intermedia cyst, Rathke cyst, deviation of the pituitary to the right, and then an empty cell was another one that we had found. This is another, I took way too long to figure out how to do this. Probably took me about 2-3 hours, which I'm not technically savvy, but if you want to learn how to do it, email me, because it took me a bit. So as discussed before, with Dr. Kuwabara, we went over the 39 abnormal MRIs, and 4 of those he disagreed with their reads and basically added things to them. Didn't necessarily take anything away with any of the studies that we looked through. So basically with the first one, it was a normal one, but did find that there was an incidental 2 millimeter cyst-like focus in the intermediate pituitary gland, possibly pars intermedia / Rathke's cleft cyst. Normal posterior pituitary 1 bright spot, gland volume and infundibulum. He did find that there was some T2 flare hyperintensities in the left paraventricular white matter area. Another one, there was a pineal cyst, but he found that there was also a developmental venous abnormality. The third showed a incidental pars intermediate pituitary cyst, and then a small dot in the right frontal lobe, and then the fourth incidental Tornwald cyst and borderline low cerebellar tonsils. So none of those had, so basically the neuroradiologist did not miss anything large, is the kind of conclusion we can take away from that. So going into the patients who had quote unquote relevant or kind of further workup, further referral, those 4 patients and really looking at those. Number 1, there was a 10-year-old male with a cavum septum pellucidum. Again, all these patients met criteria for migraine, chronic migraine at this point, and found that there was this cavum septum pellucidum suggestive of a cyst in that area. So the reasons for getting this MRI was migraines, now with an exertional headache, a new symptom associated with headache. So looking back on the chart, the patient sounded like intermittently on top of his headache. Sometimes he would attempt to exercise and that would worsen his headaches, which does go along with migraine. But they were sent to neurosurgery. Neurosurgery repeated the imaging and the imaging was normal. This thing actually went away. So I don't know what happened. Can you just like kind of suck up a cyst on your own? Maybe. For the next one, there's a 13-year-old female with few scattered punctate foci of bilateral white matter signal abnormality. Oh my goodness, abnormality are nonspecific and may reflect perivascular spaces or foci, which can be seen with the increased frequency of setting a migraine. That was the read on that one. So the reasons for this MRI was not missed on the face, and this kind of went into our category of transient symptoms / aura. She did not have that at the time of physical exam. And then ultimately she was referred to neuroimmunology and allergy / immunology based on MRI concerns. The MRI abnormalities actually resolved on repeat scans in December of 2022. So another one. It's a little strange. So the third one, sorry, I just double checking. All right, the third one was a 7-year-old found to have, again, T2 hyperintensities, in the bilateral central valley with a U fiber sparing, slightly more conspicuous versus prior, possible early leukodystrophy, which is definitely kind of raised our eyebrows, and then consider metabolic screen. So the reason for ordering this MRI was vomiting, which again, as part of migraines, you can have vomiting, which is fine. But you can have just nausea too. So understanding sometimes patients get concerned about that as well. But with this one, as the neuroradiologist suggested, the patient got a metabolic screen, which was negative, and then got repeat imaging about a year later and showed that this imaging was back to normal. The fourth one, 18-year-old female with a nonspecific T2 white matter hyperintensities, which favored related to migraine. However, demyelinating disease is less likely. Now, I think maybe after going through this with Dr. Kuwabara, I think there was maybe a potential kind of not misreading from the neuroradiologist perspective, but potentially from the neurologist perspective. He when we were discussing, he's like, I would have probably done a sort of demyelinated or recommended demyelinated workup. He's like, if we are a little bit concerned about it, we put it in there. If we're not concerned about it, we don't put it in there. So the reasoning for MRI for this patient was frequent visual auras and re-eval with prior white matter lesions. Again, this one was in the context of headaches. So we did include these patients, or this patient, excuse me. And then again, we discussed kind of the discussion with neurorads where these lesions were slightly larger and more than expected compared to the ones where it's like just a little, maybe 1, 2, 3 little spots of white matter hyperintensities. And then from our standpoint, kind of looking, retrospectively, we probably would have done a demyelinating workup. So just something very interesting. I do have just a screenshot of that one, which you can see. I don't know if you can, I don't know if my little pointer is working, but that's okay. But you can see kind of on the right sort of kind of parietal side, and then on the left sort of almost, it was, when we looked at coronal, it did very slightly touch the kind of the ventricles, kind of periventricularly, and then there's that one more like left posterior medially, as you can see there. When you scroll down a little bit further, there were a couple more kind of in the frontal lobe, a couple more like on the right posterior. So there was quite a few, and just not entirely typical of what we normally see. So this just kind of goes over the reasoning from the neurologist or APP's perspective of why they had ordered MRIs in these patients. Number one was being worsening headache, seemed to be the most on both sides. This is for reasoning of all the MRIs and then of the abnormal MRIs. And number one was worsening headache. Number two was a new symptom associated with the headache. And number three was the atypical location. Okay. So sort of going into the discussion points for this in general, there definitely were areas of improvement or that could have been improved. I mean, with any study, there could always be areas for improvement. The sample size, we could have done like a larger time period, which may have taken us twice as long to get to the numbers that Turkey had gotten to. Potentially too many exclusion criteria, but at the same time, I mean, we were very detailed and really wanted to make sure we weren't missing anything. So, I mean, maybe a plus or a minus. The difficulties with the study I kind of talked about before a little bit, but so there was a lot of, when we're going through the physical exam, there's a lot of variability in patient exams in general, and some of those can be, within the realms of normal. So a couple things were like, mild bilateral hyperreflexia. It's like, okay, they're a little bit more jumpy in their patellars, but it's not asymmetric. Like, would I get a scan for that? Probably not. Sometimes patients would have difficulty with some fine motor movements, that sort of thing. So the ones were kind of on the various ends of variance, but the reasoning groups were quite difficult, as you could see. I mean, a lot of different reasons, and it seems like, oh, this is very straightforward, but it was kind of hard to place some of these rationales in different places. But ultimately, I mean, we came up with a relatively extensive list in general. So braces was really kind of unfortunate for our study. I should have maybe tallied how many total patients with braces, but I mean, I think it was at least 20 to 30 patients, which is almost, 10% of the study. I mean, the MRIs were obstructed by braces, which I think we need to be a little bit better as physicians about, like, it's kind of sucks. Like the family should know, like, okay, well, we have braces, but it may or may not be that helpful in this context, because we might not be able to see everything. And I think we're all guilty of it at some point. So it was kind of difficult and kind of like shucks for this patient population to kind of take it out of our thing. Not all of the physical exams included a fundoscopic exam. Again, we didn't look any sort of at the prior charts prior to the window to see if they had gotten a fundoscopic exam before. A lot of them did have it, but not all of them. And I think it's an important kind of topic that always needs to be kind of readdressed and rediscussed. Because in general, if you don't do it, you don't get better, and you might miss something ultimately. In these patients that you don't want to miss. Areas that we could do for further investigation, whether that's based off of this study or in the future on other studies, is we could really further analyze those excluded and their findings in a separate study. We didn't even look at those MRIs. Again, quite a few were from neurosurgery. Quite a few actually were like hem-onc patients, but again, like we could look at hem-onc patients at some point in the future and see how many of those had initially presented with headache. But looking at that literature, it's also very, very low. I want to say it's like less than 5% with those patients too. Another one is kind of the psychological impact of getting an MRI, both for the neurologist and the pediatric population. Psychological impacts of discussing these study results, and something I want to quickly kind of address, or a study that's kind of at the bottom that Dr. Little actually had brought up to me was one that was done and really looking at basically patients who had a high degree of anxiety or stress in their lives versus patients who had basically low anxiety patients. And then also the general, actually these were kind of questionnaires that went to both the patients and then also the general practitioners, not neurologists, and tried to see, okay, did this, number one, decrease anxiety? Number two, did it decrease costs? And number three, did it change management? So number one, for patients with high degrees of psychological stress, they did find that initially after getting an MRI at that 3-month mark follow-up, they did see a slight decrease in the anxiety, but after a year really didn't show much decrease in stress or anxiety in these patients. They didn't really go into why the patients felt that way, but what I can maybe assume would be like, okay, my headache's still not getting better. Is there something that they missed and now it's growing, that sort of thing. However, for those patients, again, this was with the general practitioners, it did actually have somewhat of decreased costs with these patients because the physician or the general practitioner themselves felt more confident in their diagnosis after the MRI. So that led to less follow-ups and less referrals, so maybe a decrease in overall costs. So basically, the main benefit seemed to be more for the general practitioners rather than the patients, because they seemed to be more reassured that by the scans, which helped them manage them more efficiently without using further investigation. So just an interesting study. It may show that maybe I need to do this talk with the kind of general pediatrics group as well. I talked a little bit about the financial impacts and then the impact of incidental findings on patients and families. That still kind of goes into sort of the psychological effects. Because I know even when we discuss incidental findings with our patients, they're still concerned, is the cyst going to pop or is it going to grow or this and that? And I think, a lot of them do believe us, but at the same time, there's always a hint of doubt because I think in general in our society, there is becoming sort of this increase in distrust towards medical providers. And that's something I think we combat internally, but also the patients probably combat as well. So in conclusion, 76% of patients with pediatric migraine had normal imaging, and 21% had incidental findings. Of those included in our study, 4%, or 2.4%, were considered relevant and went on to get referral or imaging. And of those 4 patients, 3 were acted upon but did not have any significant, intervenable findings or management. And then 1 we probably would have done or recommended further workup based on the findings seen on MRI. The most common reason among pediatric neurologists for ordering MRIs was worsening headache, which is a red flag based on, if I were to scroll-poly all the way back up. But none of the patients actually had relevant findings, and that wasn't, when we looked through those 4 patients we just discussed, none of those had that as a reasoning for getting their MRI. Another kind of conclusive finding or conclusive discussion point, it would be that neuroradiologists may or may not always comment on incidental findings seen on MRI, which we kind of saw after the review of the abnormal MRI findings. in these patients. And then MRIs did not significantly change the management in the pediatric population. So this presentation and eventually poster will be presented at the June AHS conference, American Headache Society conference by Dr. Laura herself. But yeah, so it was a very interesting study. We had a lot of fun doing it. I will potentially, I don't know if I'm allowed to, or I can send it separately. There is a survey that I would love for anyone who's able to order MRIs to fill out, just to see basically, like, did any of this make you kind of change the way you view pediatric migraines and ordering MRIs? I can see if we can put that in the chat at some point if you don't mind clicking. It's only 4 questions. They're super quick. 3 of them are quick multiple choice, and the last one is like maybe like you could write a couple words, just so we can even maybe use that as a data point for the future to see if this will help us kind of change our management in the future or not, which would be fine too, because, you know, if you believe it's indicated, it probably is. These are the references kind of going through the various things that we looked at, obviously. And then I would love any sort of questions, critiques. Again, special thank you to Dr. Bhatia, Dr. Little for taking a look at my presentation and giving me a couple more kind of discussion points and things to ponder. And then, of course, thank you to Jason and Victoria for helping out with this project, because it was quite an undertaking. And, you know, I couldn't have done it without them, frankly. So.
Hi, Crystal. This is Poonam. Thank you. You actually did an amazing job presenting this. So I had been wanting to do this study for years. It was the matter of finding the perfect group of residents. Crystal clearly took lead on this and took it to next level. I'm so proud of her. And yeah, please, let us know if there's any questions or critiques or something we could have done different or anything else.
Hi there, this is Ruth with neurosurgery. I was really interested in listening to this talk, and I must admit, I am surprised coming to this from the neurosurgeon side that you did not have more operative and surgical findings, because I think since we only see the patients who do come to us, we feel as if there is a higher incidence of patients who've had migraine and had some treatment before. So I think it would be really interesting to do the opposite study, which would be to start with the brain tumors that present during a certain time and then look back and see which of those had headache or migraine.
Yeah, definitely. I think we were all a little surprised. There really wasn't anything like low grade either. So we were just like a little bit surprised, but happy in a way. Again, maybe if we had an even larger patient or larger time frame or patient population, we may have, just based on those studies done out of Turkey. So, but yeah, definitely, I think it's definitely a point that we'll probably end up doing in the future.
Actually, there has been a study done with that. John Kern and I happened to do a grand rounds for the general pediatrics group. I think it was last year before, and he presented some data from a study that looked at pediatric brain tumors and looked at the most common symptoms with that. It was very interesting. He probably still has that. I don't remember it as well off the top of my head because he was the one who presented that data. But there have been studies done looking specifically at brain tumors in pediatric population and what are the most common signs and symptoms. And although headache certainly can happen, it's not isolated headache. I think that's one of the take-home points from those studies is that people don't just have intermittent headaches if they have a brain tumor. One quick comment and then a question for you. The question about worsening headaches and imaging is a very subjective one. We know from the American Migraine Prevention and Prevalence study that it's very normal. The natural history of migraine is for it to fluctuate over time. You go through phases where it gets worse, you go through phases where it gets better. So there are a lot of people who come in who, transition from low frequency episodic migraine to high frequency episodic migraine to chronic migraine and back and forth. So that's usually not in and of itself an indication, even though worsening headache is listed as that. But my question for you is, based on the information that you have from this study, is there anything that you would tweak? Is there anything that you would change about the criteria for imaging?
Let me see if I can go back to my criteria. I mean, I wish we were all perfect, and I wish everyone. I think that was the biggest thing that was tough in ours, because no one. I can't go back fast enough. Basically, no one. Like going in for the reasoning and going in for the exclusion criteria. One of the ones that was kind of difficult for us that I wish we could have maybe like added or not added with the, where is it? Hold on one second, just pull it up that way. It's a little bit easier for everyone to take a look at. So it is methods inclusion. There we go. Oh, yeah. I mean, some of the ones that we wanted to look at purely migraine, and one of the ones that was really kind of difficult in the end for me to kind of want to like add or take out would have been the kind of doing the repeat imaging for the sake of just even doing repeat imaging too. Sometimes I feel like we should have included those because a lot of them, I mean, even when we were looking at those patients, they did have chronic migraine. And the tough thing with that one was like a lot of them, and none of them had intervenable findings either. So I think it would have just given us a little bit more ammo even on top of it too. So that was another one. It's like, okay, we could have taken out, we could have left in. It was sort of up in the air every time. But I think also the other thing too, when we want to think about this, we shouldn't just be repeating imaging for the sake of repeating imaging in these patients who have a normal neurological exam and really aren't showing any the more objective criteria of the SNOOP red flags. So that's when I was just, I think we had a lot of internal sort of discussion amongst the four of us on whether or not to kind of include those patients. But I think there's a lot of, I wish our patient population would have been a little bit larger. That's always something I wish we would have had. Because I wish it would have been like 300, 500 patients, but I think we would have needed a lot more manpower, and we were thinking about getting a medical student, which looking back, this is way more complex for a medical student, and then is at much higher risk of kind of, because of their level of knowledge, basically a lot more mistakes could have been made. And the fact that we went over it kind of so many times with those kind of questionable patients, I think it was pretty helpful too.
So I also have an additional comment here. Rob, this was actually the hardest for us. We actually did tweak the exclusion criteria. The biggest thing that was a problem for us was soft neurologic findings, as Crystal has, mentioned. There were good 10 to 15 patients with that, especially, for example, kids with autism, with, subtle fine motor difficulties and stuff like that. So we actually did tweak one of the criteria, the one that says previous neurologic, and we said anything that could confound the assessment of migraine or MRI. But I think the big one, if I personally have to go forward and order, I mean, bingo, you said worsening headache, very loosely used term. Migraine is known to do that. So, unless it is something like headaches are waking you up in the middle of the night, or there is something else associated with it, seizure or cognitive or other things, those would be clearly the criteria to order the MRI versus just a loose term worsening headache. And the other thing that I actually did not find, yeah, thank you, Crystal, surprising was, family history of brain, again, parental anxiety. Family history of brain abnormalities, the reason my kid has, yeah, you say migraine-like headaches, but please get an MRI. And if I may say, we get cajoled into doing that. Couple of other things like, history of trauma. Not every trauma leads to a brain abnormality. So if I have to say, I think all of these need a better look, each and every of these indication. And, retrospective studies, really hard to go into the mind of the person who was ordering it. But we really wanted to clearly emphasize that unless there is something associated, like you mentioned about the tumor study, unless there's something else associated with pure migraine-like almost never you will find an actionable item.
Let me see a question from Dr. Chapman in the kind of chat. Since we are focused on space-occupying lesions associated with migraine, is there utility in doing MR fast instead of a full MRI? And actually, that was a question I was also posed from a psychiatrist when I was kind of just briefly discussing this with him, and he was like, "Well, why not just get a CT, make them feel better that way too," which that has its own kind of implications from that standpoint as well. I think from the neuroradiologist standpoint, they're technically only allowed to comment on certain things for those. But I think that definitely could be, something that could be helpful in these patients, especially like save them some anesthesia. I know there is some kind of talks about getting a, what's it called, this kind of movement camera in the MRIs that are in the actual like MRIs we have here, and using the camera to actually move with the patient's head and face to get a clear image even without anesthesia. I know that's still in talks. We don't have that yet, but that was something I actually recently heard from Dr. Miller as well. So if we could do a shorter one and the neuroradiologists feel more comfortable with kind of commenting on some of those other findings rather than just ventriculomegaly, hydrocephalus, then I think it's definitely an option and definitely something that we could probably consider and would probably be of a lesser sort of cost, definitely from an anesthesia perspective as well. So.
If I may comment on that real quick, the American Headache Society does have a position paper or a position statement on that very subject, and they do specifically recommend an MRI instead of CT, except in emergency situations. They do not specifically comment on fast MRIs, but they do. If you're going to do imaging for evaluation of headache, MR is superior to a CT scan. I think depending on what you're looking at, the radiologists do always hedge with those fast MRIs. So it's the case that if that's a more limited evaluation, that full MR would be preferable based on the American Headache Society position on that.
And then Dr. Williams is saying, I don't think the price is any different from a complete MRI. I don't know. I haven't looked at those numbers personally. Well, thank you everyone so much for the discussion points and things like that. I will probably send out like a little email to people to see if you guys could potentially help me in doing that little survey just to help for kind of some quality improvement measurements going on in the future. All right. Thank you again.
Thank you, Crystal.